Hi, my name is Jessica Wyatt, and today I will be presenting to you on increasing breastfeeding rates in low-income women as a factor of cancer prevention. What is the public health problem? In 2017, 250,520 new cases of breast cancer were reported by the CDC. Among women, breast cancer is the second most common cancer, and ovarian cancer is the fifth most common cancer. This data is compiled from cancer registries around the U.S. cancer statistics. The data covers 100% of the United States population. So as you can see, breast cancer has fairly high rates, and one thing we already know affects breast cancer is breastfeeding. So, breastfeeding decreases risk for development of breast and ovarian cancer. This is believed to be related to the decreased exposure to hormones like estrogen, since estrogen is decreased dramatically when a woman is breastfeeding. And what we know about low-income women is that they are less likely to breastfeed than higher-income women. Although breastfeeding started off as something more low-income women did, over the years, gradually formula became more introduced to the low-income communities and now is a staple. So some of the determinants, the reason why low-income women are less likely to breastfeed, are related to less education on breastfeeding benefits, less social support for breastfeeding, needing to return to work sooner and not having a supportive work environment, and as well as high access and support for formula feeding. The total population, the proportion of infants who are ever breastfed was lower in low-income families at 57% compared to infants who were ever breastfed in high-income families of 74%. Why is this important? Why is this problem important to low-income women? Well, besides the benefits that we already discussed for the mother, is the decrease in breast cancer and decrease in risk for ovarian cancer. There's also a decrease in risk for type 2 diabetes and high blood pressure. For infants, there's a decreased risk for asthma, obesity, type 1 diabetes, sudden infant death syndrome, and gastrointestinal infections, as well as breast milk is a ideal nutrition that is specialized from the mother to the infant. This quote by Dr. Ruth Peterson of the CDC states that breastfeeding provides unmatched health benefits for babies and mothers. It is the clinical gold standard for infant feeding and nutrition, with breast milk uniquely tailored to meet the health needs of a growing baby. We must do more to create supportive and safe environments for mothers who choose to breastfeed. In order to properly support breastfeeding for low-income women, we need to determine what the barriers are for them. By using different health promotion theories, we can come up with the different barriers that they might be facing. From the expectancy theories, articles by McMillan and Kosher showed that supportive environments, control of the ability to breastfeed, and belief in being able to breastfeed were some of the biggest barriers. From the threat and fear appeal theories, some of the biggest barriers, as reported in Lorenzo and Bellew research, was the support from healthcare workers, lack of education on breastfeeding demands, and low societal support. From the stage model theories, articles by Henry and Humphreys, the barriers determined were lack of education availability, low self-efficacy, and lack of resources. And lastly, from the social cognitive theories articles by Edwards and Noel Weiss, low environmental support, decreased self-efficacy, lack of educational materials, and lack of educated individuals throughout the community were some of the biggest barriers to breastfeeding. As we can see here, the two most common barriers reported from all four of the theories used were self-efficacy and social support. So this will be important to continue to look at further on when we start to look into the types of interventions that would be most useful. For determining which behavior theory discussed helped better understand the topic of breastfeeding, I think that the theory of planned behavior showed a great understanding of the risk factors and protective factors. The barriers of breastfeeding low-income women were self-efficacy and the ability to breastfeed, the social norm of the behavior, and the perceived ability to be able to do it. So those are represented in the theory of planned behavior as the attitude, the subjective norm, and the perceived control. All of them played a role in the intent to perform the behavior being breastfeeding. So if we use this theory to look at breastfeeding, we can see each of the three most common barriers represented in the three main constructs of the theory of planned behavior. Moving on to interventions used in breastfeeding promotion, the types of interventions used were different based upon the theories. In the expectancy theory, one article by Josiah used a computer-based education program for low-income women. This program was helpful in increasing the number of women attempting to breastfeed, but only when they used the program. Women needed to have a certain level of motivation on their own before they would use the program. Through the zoo intervention research, there were individual instruction, group activities, and telephone support. This was more intensive and more involved. It increased the amount of women breastfeeding and the duration of their breastfeeding. Moving on to the theory of fear appeal theories, an education based on promotion of benefits to negate negative factors by Jones showed that the promotion of benefits without teaching about the struggles decreased the rates of continuing to breastfeed. So proactive interventions were more successful than reactive interventions. And this is important in the postpartum period because mothers are very busy and don't often have the time to think about themselves. So if someone is coming to them with the intervention, it's easier and more likely that they will use it than if they have to seek out the intervention when they need it. Next, we will look at the stage model theories, like the trans-theoretical model. Bensley and Crumble both used this model. The first one was an internet-based education program for WIC participants. Again, women who were higher on the stages of change were more likely to use the internet-based program. And of the women who did use the program, there was an increase in the behavior of breastfeeding. Crummell used a differentiation of resources based on the level within the stages of change, trying to provide a more individualized intervention and meet the women where they were at. The results show that progress was seen throughout all of the stages, but the biggest increase were those that were in the action stage and in the maintenance stage, which is similar to the results from Bensley. Lastly, the social cognitive theories. Two of the interventions that I looked at were, first, within the hospital, women were encouraged to keep a breastfeeding log and share it with a professional to help increase self-efficacy. This showed the women how often they were breastfeeding and how well breastfeeding was going for them, and helped encourage them to continue doing it. They were able to look back at their logs and see what they had done and how far they had come. The results showed an increase in duration and rate by a small percentage. The Wood intervention was much more involved. There were in-person, in-home visits, hospital visits, phone calls, access to a professional lactation consultant, and some group activities that were available, all within the first 6 weeks of birth. The results from this intervention were a much larger increase in both the rate and duration of breastfeeding by a significant portion. After looking at all of the barriers and risk factors for breastfeeding and the different interventions used, I concluded that social cognitive theory would be the best theory used for breastfeeding promotion. I have multiple reasons for this, but mainly the three biggest risk factors were related to belief that they could do it, personal factors, the behavior of breastfeeding, which there is a learning curve that they had to get over, and the environmental influences, because breastfeeding is not always supported in different communities and in the society as a positive thing to do. So using the social cognitive theory, we can address the behavior of breastfeeding to help them learn how, increase attitude towards being able to breastfeed, and provide assistance with support in communities that may be unsupportive. So my suggested intervention strategies for low-income women are to begin before birth by providing an education program in person where women can learn how to breastfeed and be able to ask questions and get a feel for what it might be like. This will help them feel supported and give them some self-efficacy. Next, after birth in the hospital, a proactive resource of having a professional lactation consultant come in and support the women on their journey to breastfeeding. I think with this feature, it's very important that the professional coming in is proactive and standard, because if it's a reactive resource, people are less likely to use it, especially in the sensitive time of after childbirth. Lastly, to go with the environmental support, I think that we should follow up with women who are breastfeeding with phone calls and offer appointments, and really have a professional there being proactive, seeking out to talk to these women about what they're going through, asking them questions, and assisting with difficulties that they may be having. Some concerns that I could see would be the financial investment of having a program that is that involved, equitable treatment of having all the low-income women being treated equally and fairly, and then cultural and language barriers, because there are different ethnicities and different cultures who are low income and might have different opinions on things and how they should go. To leave you with, I want to read this quote. Given the importance of breastfeeding on the health of mothers and children, it is critical that we take action to support breastfeeding. Women who choose to breastfeed face numerous barriers. Only through the support of families, communities, clinicians, healthcare systems, and employers will we be able to make breastfeeding the easy choice. Thank you, and I hope you enjoyed learning about breastfeeding in low-income women and how we can help support that.